found this quite a helpful and very simple diagram to help me think about what's going on in patients who have raised intracranial pressure. If you have an increase in the intracranial volume, given that the skull is a very non-compliant case, then as your volume rises, you will very rapidly reach the limit of compliance, and you will find that intracranial pressure rises extremely quickly. If you look at what people's GCSs are, then a GCS of between 13 and 15, so slightly confused or slightly drowsy, correlates with an intracranial pressure of less than 20, but by the time you're getting a GCS of less than 8, then you've got a very significantly raised intracranial pressure, which therefore means that you've got very significantly reduced blood flow. And the fact that this curve is so steep in this part means that you really do have to move quite quickly once you start getting signs of intracranial pressure raise. So what do you do to manage raised intracranial pressure? It's ABC, so you give the patient high flow oxygen and you correct hypotension. Now most patients won't have hypotension, they'll be hypertensive, but it's important that if for whatever reason they are hypotensive, that they can mount a mean arterial pressure, which means that you will get perfusion. You can position the patient, and that may be head up or head down or neutral, depending on what you think the specific circumstances for the patient is. Just going back, actually, a central alignment of the head is most likely to be advantageous, since you want to optimize drainage of blood from the brain. Then you need to reduce edema, and the effective way of doing that is by giving mannitol, because that acts very quickly, and that's given as a rapid infusion over about 30 minutes, and will have its effect in that time. The effect of mannitol lasts for about 2 hours, so you've bought yourself 2 hours of improved cerebral perfusion. Dexamethasone will reduce edema, but of course it takes some time to begin working, so the two should be given at the same time. If a patient has had neurosurgery, then they may well have a shunt, or they may have an Amaya reservoir. I've misspelt Amaya on that, there's 2 M's. Now the important thing here is that if someone has an Amaya reservoir, then they have an emergency valve, and it is very easy to take off a few mils and have a very significant effect on cerebral perfusion. If a patient has got an Amaya reservoir, it would be my normal practice to tap off perhaps 5 mils of fluid, checking the opening pressure, providing it's safe to do so, and that means that making sure that they're clotting and the platelet count is safe. The next thing you need to do is to image the patient's head very rapidly to make sure they haven't had an acute hemorrhage. Now that's normally done by CT because that's more available and it's a more rapid procedure, and to do an MRI on a patient with raised intracranial pressure means that you have to put them in a difficult environment where you can't fully observe them. So a CT is the more commonly used emergency procedure, and then depending on what you find, you need to treat the underlying cause rapidly. Let's talk a little bit more about the further assessment of these patients. So, when you come in to see a patient who may have raised intracranial pressure or may have neurological deterioration, then posture is quite a useful thing to look at. And the things that you need to be aware of as the patient hypotonic, or have they got specific positioning of their arms and legs, decorticate or decerebrate posturing. Now hypotonia is common and really isn't a very useful sign, it just means the patient's ill, and it's seen in lots of patients, especially young ones. Decorticate and decerebrate posturing, however, is really very worrying and implies that you're beginning to get significant shifts of the brainstem. Decorticate posturing is when you get flexing of the arms and extension of the legs, particularly in response to, for example, pain. Decerebrate posturing is when you get extension both of the arms and the legs, and is a much more worrying sign again. Eye movements are helpful, and again, if you're assessing a patient who has reduced level of consciousness, it's worth looking specifically at the eyes if they're closed or open. If you've got a patient who's got spontaneous full conjugate movements, and the movements go across the midline and they have normal pupillary reactions, then you've probably got normal brainstem function. You've certainly got normal 3rd, 4th and 6th nerve function, and internuclear function as well. And that would be, of course, somewhat reassuring. If you have a patient who's got persistent conjugate deviation, then you have to think about stroke or possibly seizure activity. A subclinical seizure may not give you tonic-clonic movements, and certainly there's some value in some cases giving a trial of anticonvulsant. Persistent downward deviation is relatively uncommon, but it is associated with upper brainstem compression, or perhaps a lesion involving the thalamus, which is pressing downwards, and including the tectal plate. If a patient is in coma, then they usually have eyes which drift around, they rove, they don't have the normal saccadic eye movements, so your eyes don't fixate and then move rapidly to another point and fixate. And that's quite an important thing, because every now and then you get a surprise when you find that a patient is feigning coma. If you're seeing saccadic eye movements, then it is quite uncommon in the unconscious patient. Pupillary responses are also important. Equal, brisk response to light suggests that you have a normal brainstem, and if a patient is in coma, then you may well have a cause such as a metabolic cause rather than a primary brain abnormality. If you have pupils which are equal but rather sluggish to respond, then it's quite a non-specific sign. It may be associated with quite a lot of drugs, and of course you may have interruption of the optic nerve pathway, so you may have optic nerve problems or retinal disease. Patients who've got unresponsive pupils which are large points towards midbrain pathology, involvement of the oculomotor nuclei. If they're mid-size, then you think about central midbrain compression, and that's because you're getting both the sympathetic and the parasympathetic supply also affected. But again, both of these point to brain stem involvement. If you have small reactive pupils, then you think about opiate toxicity, but again you can also get compression from above, early rostral brainstem compression. That will obviously change as compression increases. And then very rarely you may get a primary pontine lesion, which gives you a similar picture. Fixed, dilated, but unequal pupils. It's worth thinking about an ipsilateral, about 3rd nerve palsy, and this may be associated with an uncal herniation. I'll talk a little bit later about the herniation symptoms. But the uncal herniation is where the hippocampus is compressed against the tentorium. Okay, so these are the various herniation syndromes that may arise. So we've got here number 1, which is herniation of the uncus, or the hippocampal gyrus, pushing through the tentorium. And that's relatively common abnormality when you have a lesion in the cerebrum. Central herniation is seen, again, if you have a lesion in the cerebral compartment. You can get what's called cingulate herniation when you get the cingulate gyrus being pushed across the falx, and that gives you a very non-specific picture, and may in fact be one of the earliest signs, and isn't necessarily associated with a grave prognosis. Occasionally you have patients who've had an operation or an injury where bits of brain start poking out through the skull. That's called transcalvarial, and that should be fairly obvious. And then occasionally you get upward herniation for a posterior fossa lesion, which doesn't go down but instead pushes upwards. That's and then finally any expansion may lead to brainstem herniation downwards through the foramen magnum, which is a very worrying sign. This picture I've not acknowledged. I found it on Wikipedia, but it didn't have any reference with it, so I hope I'm not infringing anybody's copyright. So the process of herniation is dangerous because tissues moving in the brain is not a good thing in general. You cause pressure, you cause ischemia, and you can lead to tearing of vessels and hemorrhage, all of which are just not good for the brain. So these are the various herniation syndromes that we can talk about. One is the cingulate herniation, and this is when you get a lesion arising in the cerebral cortex, and you get pushing of the frontal lobe, in particular underneath the falx, and that leads to ischemia and local damage. You can also though get secondary raised intracranial pressure, leading to more severe herniation, and this gives various pictures, various clinical pictures with abnormal posturing and coma. But the important thing here is that if you treat it rapidly, you may well find that it is reversible without injury. Uncal herniation is when the medial part of the temporal lobe is pushed through the tentorium, compressed on the upper brainstem, and you get third nerve compression, so you get eye signs, you get eyes pointing down and out, you get unequal fixed dilated pupils because of third nerve palsy, you can end up with a unilateral ptosis, and you may get a hemiparesis on the same size as the lesion. But again, this may well be reversible with good outcome. You can get what's called a diencephalic herniation, which is herniation through the tentorium again, but on both sides, and you get a degree of compression of the midbrain here as well, so you may end up with small or midpoint pupils which can react to light. You get a flexor response to pain, and you may well get decorticate posturing, hypertonia and hyperreflexia with extensor plantars, and you also start getting abnormal respiration pattern. And the problem here is that you may well get basilar artery damage, and if that does happen, then the patient will die. If that doesn't happen, then you may well find that this is reversible. More severe herniation involves herniation of the midbrain. There's an arm missing, or the upper pons, and again you get changes to the pupils, you get extensor posturing to pain and hyperventilation. And the worst scenario is when you get lower pontine and tonsillar herniation through the foramen magnum, and you get severe compression of the lower brainstem and upper cord. You get midpoint pupils which are fixed to light, you get no response to pain or flexion in the legs only, you get flaccidity with extensor plantars, and respiration by this time is shallow and discoordinate or ataxic, and that situation is irreversible. So that's we're at the end of what I wanted to talk about. I've given you an indication of some of the underlying causes for a reduced level of consciousness, and I've spent perhaps a little bit too long on primary CNS lesions, but the reason for that is that my concern is that many of these problems are under-recognised. It's important to think broadly, think about all the possible underlying causes. It's important to make a rapid assessment of consciousness and to act rapidly to avoid permanent injury. So thanks very much. I hope you enjoyed that talk.